And the gross appearance, well, the other thing that pathologists do, and before there were microscopes, this is all they did, they made a diagnosis based on the gross appearance, and you can still say a lot. So this is a breast specimen, and you see the black ink here on the side, and the knife cut a slice into this, and you see this white area right here. This is fibrocystic change. This is not cancer, even though it's pretty ill-defined at the edges. And you put your finger on it, it's all going to be soft and pliable. Next. This is different. This is much firmer. It's protruding onto the surface as you have cut into it. And there are little areas like the one up there, another area over there, and a little spot down there, and another spot down there. This is all cancer, and it feels much firmer to palpation. So this is clearly cancer. And you see a little bit of that fibrocystic change stuff that's glistening business up here. So it's intermingled with each other. So it's not all cancer, but there's definitely cancer. Next. Present. Here's another example of a cancer that's rather large. You can see the ink surface black here and the green over here. It stretches all the way through the breast tissue. And there are spaces in here, and it varies in its quality and coloring, and that's because of necrosis. So it's not homogeneous like the previous one was. So this is probably a high-grade tumor with large areas of necrosis. Next. And this is another type of gross appearance. You see how glistening this is? This is mucus material. And if you have a mucus-producing lesion, it's going to be very soft and very gooey and sort of sticky in its appearance. And that's reflected over here with all this material in the background. All right, just a few words about lymph nodes. So you have the breast here, and then you have a chain of lymph nodes up into the axillary space. So this is the axilla here. And what's used these days is, most of the time, is sentinel node biopsy, because if you take most of all the nodes in the axilla out, you have a big risk of developing lymphedema. And so there's a technique of injecting dye and or radioactive material that traces in the lymph system to the first lymph node that drains the area where the tumor is. If there is metastatic disease, it's a very high likelihood going to be in that node. And then that's sent for frozen section during the surgery. If there's tumor seen at that time, the surgeon will go ahead and take more lymph nodes in order to remove further disease in the area. So next, to show you what a lymph node looks like. So this is a lymph node, and it has a membrane around it. This is remaining normal lymph node tissue. All those small dark cells, again, are lymphocytes. However, here, a big part of the lymph node has been replaced by tumor cells. So this is a pretty big metastatic focus in a lymph node. And this you can see by just looking at the node. It's going to be white instead of gray. Grayish brown, sort of as normal lymph node, and white typically as metastatic disease. And it's also going to feel much firmer when you feel it.
Do they do the sentinel lymph node for lumpectomy or only for mastectomy?
Either way.
Either way. So you could get that.
Yeah. Now this is another situation where most of the lymph node is normal. There's just a tiny little focus right here. It calls that micro focus of invasive disease. And if you see this, it's not very likely that you're going to have further disease in the other lymph nodes. And there's some debate over should you take more lymph nodes when you see this. Most people say yes, we still do that, but it may be in the future that they will not do that. Okay, vascular.
Getting on, I mean, I'm just sort of, we
I
don't want to
know,
go too
really.
late, so I don't remember. You didn't have a whole lot.
No, we're almost there. We're almost there. So this is the same picture again. So remember, these tumor cells travel through the vessels to the lymph node, through the lymph system. And sometimes tumors will actually show that they have a propensity to migrate through the system. So next slide. And what you can see next to the tumor are little plugs of tumor cells inside vascular structures in the actual breast. And if you see this, there's a very high likelihood that the patient has lymph node metastasis. And there also is the prognosis overall for that patient is less because that tumor is more likely to metastasize to other parts of the body. I think we can skip that. I don't think we're going to go into hyperplasia today. I think that's too much.
Oh,
That's
we should
okay.
finish.
I have a really cute slide at the end.
That's what we
No,
talked about
no,
before.
go
when-
on, go on, go on. Oh, so should we talk about ERPR?
Well, the last three, and go ahead. I mean,
Okay, so
this is the end.
this is, yeah, this is it. So marker studies, in order to characterize the tumor and learn about the prognosis and also what kind of treatment is going to be feasible or effective. The first thing that usually is done is to look at hormone receptors, because if the tumor has hormone receptors in the nuclei, they're more likely to respond to hormonal treatment. That would be tamoxifen or oophorectin. So we stain the sites and see if that's present. And there's also HER2/neu, ERBB2 group, and if the cells are positive for this, and that's about 20% of breast cancers, they are likely to respond to Herceptin treatment. And then you already heard about oncotype ADX and adequate, I think yesterday, so we can skip over that. Or last
Have
week.
you heard about the other markers as well?
Yeah, I think
So we can.
they did that. So here, this brown stain is estrogen receptor. You see how the nuclei, almost all the nuclei in this tumor stain very strongly. So this would be very likely to respond to hormonal therapy. Next. And this is a little bit different pattern. You see, the nuclei are not stained here, but the membrane around the nuclei